So I'm going to talk about testing cancer susceptibility genes, particularly in light of the NHS 10-year plan and the service specification for the Genomic Medicine Service, and the ambition that this type of genetic testing is taken out of the clinic, where we test people who came through the front door with a problem, and that we take this type of genetic testing out to the general population and knock on people's doors and offer them the testing. So this was my sort of the 5 ages of genomics, that we have empirical observations of clusterings in families. We began some early molecular technologies, linkage, Sanger sequencing, the Human Genome Project, that allowed us to start making clever diagnoses. We then got this whoosh of the technology around next generation sequencing, meeting big data and bioinformatics, allowing exomes and genomes to become feasible. And we have reached this point of going, okay, can we use the genome to predict what happens to us health-wise in the future? So I work in cancer, which is a large volume use case, but obviously not the only use case, but I will focus on cancer as a good example. So this is sort of looking backwards, and the state's a bit out of date, but it tells the story. Cancer incidence, absolute number of deaths rising, and cancer death rate is absolutely flat. It looks a little bit better when you age standardise the mortality in the years of life lost. So that flatness, you are getting a little bit of decline, which is essentially that given that our population is aging, we are getting a little bit better in terms of cancer mortality. But as you go forward, this is what's putting the fear of God into politicians, is this increase in the incidence of cancer and the implications of caring for those people, and particularly in regard to the mortality, providing that end-of-life care. So, very attractive. Can we address this burden of cancer through SPED, screening, prevention, early detection? So the premise is not a big surprise. When you diagnose cancers at late stage, there is a pretty poor survival rate. So this is for lung and this is for bowel. And the converse is, of course, if you can diagnose at an earlier stage, then you have higher survival. And then this is looking in more detail, stage 1, 2, 3, 4, at the percentage, that's 5-year survival for colorectal cancer. So you can see that really telling story of late diagnosis and that poor outcome at 5 years. And that was the basis for the NHS long-term plan, or the last long-term plan, which I think was 2021, announcing the ambition that 75% of cancers should be diagnosed at stage 1 or 2, and it was at around about 55% at that time. So this was the plan they articulated, which is a slightly flawed ambition, but either which way, they've sort of quietly screwed up that and thrown it in the wastepaper basket because they have not met it at all. But nevertheless, the new long-term plan expresses ambition around earlier detection and diagnosis. So earlier detection and diagnosis, so one way you could approach that is if you take patients when they present with symptoms, wouldn't it be good if we could diagnose them really quickly? And that was the whole premise of the 2-week wait, the 31-day, 62-day targets, that let's detect symptoms rapidly, get that cancer to a surgeon, get it in a bucket. That is a very, very effective way of mitigating cancer. The problem is that actually many cancers, particularly deep abdominal cancers, do not present with symptoms until a point at which the cancer is already spread. And so even if you can be super prompt, it is still a late stage diagnosis. So it's very attractive to say, can we go upstream in this oncogenesis of pathway, oncogenesis of cancer, of this pathway of oncogenesis, and detect the cancer pre-symptomatically. And hopefully we get more of them up here, and then that would mean that we catch them before they're metastatic and we can cure them. And so we have 3 national screening programs: breast, colorectal, cervical, and screening for those at high risk of lung, with exactly that purpose. And of course, even more attractive is, can you prevent cancers? Can you intervene at this stage and stop the abnormal cells from becoming dysplastic and then invasive. So prevention is also very attractive, slightly less politically attractive in a way, because people don't know they've had their cancer prevented, so they're not quite so appreciative as having had it caught on screening or detected early. So as I said, we have 3 national screening programs for cancers, but it's very attractive that we could identify individuals at high risk of cancer, so not screen everyone, and then we could offer them this marvelous array of interventions which would be neither economically feasible nor clinically acceptable to offer to people who are at standard risk. So of course, rather than screening, we'll take breast cancer as the example, rather than screening 3 yearly from age 50, if you're at high risk, we screen you from earlier, we screen you more frequently, and we screen you with more multimodal screening and more expensive sensitive modalities, so using MRI potentially in combination with mammography. We could do primary surgical prevention, so I'm sure you're all aware of risk-reducing mastectomy, but we do also do risk-reducing colectomy to remove the colon, gastrectomy, and then salpingo-oophorectomy. Primary chemoprevention, taking a drug when you are well to prevent cancer, and the new sort of sexy term is interception, that you sort of catch it just on the upflick, so you don't take it as you take it sort of a little bit later on with some biomarker which tells you when to start. So aspirin used for colorectal cancer, metformin under study in people with TP53 mutations. Tamoxifen aromatase inhibitors we use for women at risk of breast cancer. And then there are sort of other drugs under trial. Denosumab is a drug for osteoporosis, which has shown efficacy in mouse models, BRCA1 deficient mouse models. There's a lot of interest, particularly from Yorkshire Cancer Research. They really want to do a PARP inhibitor prevention trial. PARP inhibitors being used for therapy, and particularly effective in breast cancer patients. So that potentially will be a trial. And then, of course, behavioural interventions, which be variably palatable to different people, but more palatable potentially if you're at high risk. So all of these things we potentially can target at people. And in regard of breast cancer, we have over the last 30 years identified a wealth of breast cancer susceptibility genes. So these are the people to whom, this is one group of people to whom we potentially offer these interventions. So just a few things to think about. As I said, a lot of this is driven by what next generation sequencing has afforded. So this is what, when I started my PhD in 2007, we were still doing CSVE. We were running gels up. And this was really low throughput and really laborious. And this was what they were doing in the diagnostic labs as well, which meant if you were ordering a BRCA test, they were running it exon by exon, gene by gene. So if you go, I think the family looks a bit more like BRCA2 than BRCA1, let's start with BRCA. It was a carefully thought out decision ordering that test. You ordered it gene by gene, and you only ordered it in someone who you had a reasonably high index of suspicion. By the time I finished my PhD, the next generation sequencing was just being adopted by the labs. And now clearly the labs are all on, doing very high throughput NovaSeqs in most of the labs, and doing whole exomes, whole genomes, very large panels as routine across the diagnostic labs. And that means actually that the cost of sequencing 2 genes is roughly the same as the cost of sequencing 200 genes in terms of wet lab costs. And it becomes much, much more efficient to just run very large assays, to run fewer large assays and have a much more standardized offering. So what this means, if we sort of think about the arc of time, is that back in 2007, as I said, in terms of breast cancer susceptibility, we only tested 2 genes, and we only tested you if you had a pretty strong family history and personal history. If you go to what we're doing now in Europe, we test 7 to 10 genes on our breast cancer panel. R208 is what's called for the English NHS offering. We've lowered the bar somewhat. You need a less remarkable family history, but maybe you need bilateral, young onset, triple negative, a bit of family history. If you go over to the States, however, They're not quite testing all breast cancer, but there were the new ASCO guidelines are pretty much in that direction. But there's the NCCN guidance has got all kinds of different family histories which do not need to be verified. And they've got these various programs where they're actively trawling the EPR to find out you have this family history. So actually the test is offered on a fairly broad and vague family history. And they've moved well beyond testing 7 to 10 genes. The American breast cancer panels tend to have about 20 genes, but increasingly, rather than just offering that breast cancer panel, they offer a pan-cancer panel. And the reason for that is, in part, as I said, it costs about the same, but actually the insurers tend to only reimburse for one genetic test. So if it costs a bit about the same, it's very attractive for the clinician to just offer this large cancer panel, because you don't want to offer a breast cancer panel and then like find out that Uncle Bob actually had bowel cancer and you need to do this on the guidelines, or you'll get sued, because it's obviously a much more litigious healthcare system. And also kind of commercially, there's a lot of advertising that this panel's better because it's bigger than this panel. So all of this is a sort of snowball towards testing more and more genes for what is a fairly kind of unremarkable low risk indication. So we're testing more individuals for more genes. And of course, when you find something, it's not just your proband, then you would test, you cascade in the family. So you would then sort of be getting 2, 3, 4 additional carriers from every proband you find. So, and I'm talking about this sort of expansion of our model of germline testing based vaguely on personal or family history of cancer. What I've sort of spoken about the model thus far is testing on personal or family history, and that's sort of our classical clinical genetics model, and that's expanding. But actually these cancer susceptibility genes, we do more testing in oncology. So some of that's constitutional testing of blood because it's your eligibility for a PARP inhibitor. So there's much more testing in that direction. But we're also doing tumour panels, which we're to inform oncological management and prediction. And it used to be these were hotspot panels, just had, like BRAF and a little bit of EGFR and whatever your question was. An oncology colleague was saying that if something's got fewer than 200 genes on, they call it a small panel. So they're just testing these larger and larger panels, much of which, and sequencing the whole genes on the panel. So again, many of those genes are the same cancer susceptibility genes that they're examining in the oncology context. So again, the germline mutation will be there if you sequence the tumor too. So, excuse me. So the pathogenic variants are being reported back to clinical genetics that way. And of course, ctDNA, likewise, several hundred genes on those ctDNA panels. So they're coming through as well. And then the plasma will have, of course, the lymphocyte DNA as well as the tumor-derived DNA. And then there's lots of streams by which we're moving towards population testing. So you've got sort of pilot programs by GEL, you've got whole genome sequencing, there's pilot programs of population testing for cancer susceptibility genes, so PROTECT-C being run at Queen Mary's. Secondary findings, there's a lot of enthusiasm about secondary findings, which is a sort of argument by which you get better value from your whole genome sequencing, lots of direct-to-consumer testing, and then, of course, testing of high-risk ancestry groups by the population. So all of this is in addition to that expansion of the sort of traditional germline model. And again, we were just discussing earlier that this is all pretty much laid out in the 10-year plan, that they want more of all of this type of testing. So again, we are only going to see more and more germline pathogenic variant carriers identified for cancer susceptibility genes. So this gets us to, there is a presumed ipso facto utility that this must be a good thing, finding a germline pathogenic variant. And so something I've been sort of grappling with and discussing with people over the last few years is what do people see as the metric by which we deem a gene to be useful to test, to find a pathogenic variant. And I think if you kind of talk to people on the streets or to health policy analysts, to the general public, that there would be a presumption that knowing this information is going to overall make you live longer. That would be the sort of, excuse me, health economic sort of presumption that, or healthcare efficacy presumption, it would make you live longer and or improve your quality of life, but we're terrible at studying that. So I think we have to put that to one side. Or it would reduce healthcare spend, but there would be some kind of clinical public health utility. That would be why we go looking for these pathogenic variants, because it impacts on one of those metrics. But actually, it's quite interesting that the reason all along people have put genes on panels, and we have a meeting once a year to update the test direction and we will nominate new genes, is we put it on the panel because it's nominally been found to be associated with that cancer. So there's been some publication in the literature which associates gene X with breast cancer or prostate cancer. And actually, the more studies you do, then a given gene originally just associated with a couple of cancers is then associated with more and more cancers. So appears on more and more panels. But actually, the reason that genes get added to a panel is this demonstration of association with disease, which I'd call validity, with some notion of actionability. And again, actionability is quite a dangerous word. It's like there's some action you can do. And these actions have often been sort of somewhat invented with limited evidence. But as soon as there's an action that is possible and some people are doing, that gene is deemed actionable. So if it's associated and there is some action, then that justifies testing for it. But it's quite a sort of a presumption based on those two credentials, and particularly with all the kind of complex nuances of the epidemiology of the cancer, its natural history, how effective is the current treatment, what are the different subtype profiles of that association. There's a real, excuse me, a real sort of presumptive leap that just because it's associated, just because there's some intervention possible, that you are going to improve mortality. And that becomes all the more complicated because actually, if these genes are associated with multiple cancer types, you then will have different risks for each of those cancer types. You'll have different interventions. And so you have this sort of grid. And actually, often you have a number of different interventions for a given cancer type. You might have a surgery and a screening. So actually trying to sort of figure out what is the net impact. And then you also have your proband who has probably maybe had one cancer, but all your family members who haven't. So the net impact of finding that pathogenic variant in the proband becomes this very sort of complex web of different strands of analysis. So the sort of first element of that is thinking about that risk estimation and association. And so if we take our, we used to call them HBOC genes, hereditary breast ovarian cancer, they've now been extended to being called HBOPP genes. So this set of 7 genes that we test when we diagnose breast cancer, and this is on our NHS panel. You can see our NHS panel is a lot more conservative than virtually any other of the kind of standard commercial or offerings in different healthcare systems. So let's look at these well-tested, well-trodden genes. So we performed a meta-analysis last year of 2024 of bridges, carriers, and UK biobanks. So bridges and carriers were these big case control studies of breast cancer cases and matched controls. So in this meta-analysis, we had 100,000 breast cancer cases unselected and 314,000 controls. So this was a good way of getting a point estimate, a direct estimate of the effect size. And in this meta-analysis and the constituent studies were pretty consistent for BRCA1, BRCA2, CHEK2 and ATM. Interestingly, though, even for the well sort of pretty tried and tested genes, between those 3 studies, it were very heterogeneous. The PALB2, BARD1, RAD51C, RAD51D, even though these are really kind of well-trodden genes, that they were very disparate effects because they are rare and there are subtype associations. But if we then go to the syndromic genes, so-called, which we don't test on our breast cancer panel, but a hell of a lot of the other breast cancer panels are testing those routinely in women with breast cancer. And we take, for example, TP53. So this is a sort of a kind of landmark seminal paper from 2015 lots of Cambridge authors on it. And it was sort of that was sort of at that time just trying to stop people putting any gene on a panel. So they set down some rules and standards and stipulations about what should go on a panel. And TP53 at that time, acknowledging it was familial based ascertainment, so looking at segregation in families, their best estimate for the breast cancer risk for TP53 was an odds ratio of 110. So that was from studies where they amalgamated clinically ascertained families. But hang on, in our meta-analysis of these three very large unselected studies, we got an odds ratio 3.6 for breast cancer for TP53. So again, 110, 3.6. I've swung back to TP53 is not a high penetrance breast cancer gene. But then I did a piece of work last year with Will Fulks and Mark Tiskovich, and we're actually looking at SMARCA4, which is a very rare gene. Of course, this is horrendous, dreadful early onset ovarian cancer, which typically women get in their teens or 20s. So we decided to do this analysis. If we looked at SMARCA4, and that's really all it causes, it has a little bit of association in males and females of a childhood onset neurological phenomenon, but it's really this ovarian cancer. So we said, if you looked at, you get into UK Biobank at 40, 50, whatever, let's look at the frequency of SMARCA4 mutations between males and females, because this is an ovarian cancer manifestation. It's highly fatal, highly lethal. And we actually saw a 62% depletion of SMARCA4 pathogenic variant mutations in females compared to males, which is a kind of reasonable estimate that's unbiased of your likelihood of not surviving to get into UK Biobank if you're a female. Which was a sort of, and because all of the studies were otherwise just very biased by recruitment. So we thought that was seemed a useful metric to use, kind of having had some clinical cases and not, that they have to have oophorectomy in their teams, and that's horrendous. So that's a useful study. And we thought, let's just check some other genes to just sense check this methodology. And really interestingly, the only other two genes that were significant were BRCA1, where there's about a 20% depletion in females. That kind of makes sense. There's ovarian cancers, early onset breast cancers, and particularly historically when treatments would have been poorer with a higher case-specific mortality. So that makes sense. But TP53, there's a 47% depletion. And whatever this isn't the young onset sarcomas, because that's affecting both sexes. This is some female-specific entity, which must be the breast cancer, just taking a bite out of that cohort such that the women are not getting through to UK Biobank. So again, you go, odds ratio of 110, odds ratio of 3, half of them missing. And I think what this tells us is, particularly for these syndromic genes, we've got absolutely no idea what the risks are, because all of our studies are biased in their ascertainment. The familial studies are biased by phenotype. Population cohorts, until we can get a birth cohort, we follow up right the way through their lives. But population cohorts are biased by people being well enough to engage in them at the age of recruitment. And this is for breast cancer. So we then think about other cancers. So just going back to our HBO-PP genes, we're reasonably confident of the breast cancer risk for these genes, but they're HBO-PP genes. So the ovarian cancer risk, BRCA1 and 2, the RAM genes, is always flipping back and forth. These genes associated with ovarian cancer, the prostate cancer risk kind of just keep moving all over the place. You're probably those following the kind of National Screening Committee. They recommended screening of BRCA1. There's very little evidence of association, but some studies have shown it. And again, the pancreatic cancer risks just keep varying with each new study. So again, although the breast cancer risks are pretty stable, the other cancers really uncertain. So again, that kind of comes in your package. We like to pretend that Mother Nature is simple, and that all pathogenic variants have the same risks, which is of course not true. That the risks will be variant specific, different risks for different variants, splicing variants, missense variants will all have different risks. And we also pretend that each disease is a single entity, whereas of course it's really important. Is your gene causing a risk of triple negative breast cancer, which has a relatively poor prognosis, versus ER positive breast cancer, which has a pretty good prognosis? And unless we differentiate by that, then actually our impact of any interventions would not be meaningful, because your ceiling room to change the mortality is very different between those two entities. So I think we have a lot of issues thinking about risk, even for our well-trodden genes. So moving to thinking about the interventions that we're coupling with that risk and how confident we are with those. So I'll just divert to a little 5-minute 101 about some of the foibles of screening. So firstly, your test performance. So if we're thinking about doing screening, your test performance becomes very critical. Your sensitivity for specificity, that's really important in terms of your prevalence. So prostate screening, this is PSA at 2 different thresholds. PSA has a pretty poor sensitivity for specificity, but particularly if you want to screen prostate cancer between age 50 and 60, your 10-year risk is 1 in 75, your annual risk is 1 in 750. So your likelihood, given that false positive rate with the specificity, likelihood of a true positive versus a false positive is pretty sobering. The multiparametric MRI should be getting better. This is the kind of out-of-date data. But again, each of these tests are problematic at that kind of age range. It gets a bit better as your prevalence increases, you get older, but then your life years to be gained are fewer. Stage-specific sensitivity is another big issue. And again, this is well exemplified by MSEDs such as the Gallery, Grail Gallery test. So this is data from Pathfinder 1. It's a pretty good test for stage 4 cancer. That's an 80% detection, stage 4 solid tumours. But it really importantly, the cancers that you're really looking for in a screening context are the early stage ones, where the performance is much poorer. So although it looks like a really, really good specificity, because of that poor sensitivity, again, in this kind of, I think it was a 50 to 70 prevalence, that that rate of false positives only gives you a positive predictive value of about 1/3. So although your specificity is very good, that your positive predictive value is still not great, particularly for a multi-cancer test where that is a lot of follow-up tests. But it really is that stage-specific sensitivity is a problem, because the cancers you're finding may well be ones where early detection makes no difference. So that's Pathfinder 1. And just you may have heard there's a furore in the press with the publication of, or no, the release of early data from Pathfinder 2. And that was in October, and they press releasing it. Unfortunately, they in no way in the press release, any of the subsequent follow-up, or even in the presentation at ESMO, was there any mention of stage-specific sensitivity. So clearly they've wiped that from the outputs, thinking that that's not relevant. So you're like an extremely good review of it. This and a colleague, we wrote particularly around releasing this type of information unpeer reviewed to the general media is problematic for a number of reasons, but a critique also of the study as well. So sensitivity for specificity, lead time, of course, if woman A has her cancer detected here because she's in a country where they screen, but her doppelganger twin is in a country where they don't screen, her cancer is detected later, they're identical twins, they actually die at exactly the same time from their cancer, but the woman in country A would perceive that she has survived longer since diagnosis than the woman in country B, but they have in fact both at the same time. That's the classic sort of punitive effect of lead time. The only way that you can clarify what is lead time and what is mortality benefit is with a randomized trial, which was well exemplified in terms of ovarian cancer. UK TOX and the PLCO trials look great with finding ovarian cancers. They look to be earlier stage, following them up. Absolutely no difference in ovarian cancer specific mortality. And that then overdiagnosis is cancers that are progressing very, very slowly that you wouldn't otherwise have found. in that patient's lifetime. They never would have presented. And again, the only way that you will quantify overdiagnosis is through a randomized trial, because you need that numeric comparison in two populations. You don't know if an individual cancer was overdiagnosed or not. And that's then the lovely Gilbert Welch's barnyard analogy, that some cancers are birds. They whether you find them on screening, whether you find them by symptomatic presentation, they have already metastasized. Your screening does not help them. Some cancers are snails, that they would not go, they are tiny, they were never going to cause you problems for about 300 years. You did not need to know about those. Some are a little bit bigger, going slowly. Probably didn't need to know about them, but they would present symptomatically and you'd have plenty of time to deal with them. So the only ones where screening will make a difference is rabbits, where the delta is sufficient that you catch them early on screening, you've got a bit of time, but they're progressing sufficiently rapidly that they would have been worse in their outcome if you had waited for symptomatic presentation. So you are really dependent on the natural history of your disease being rabbit heavy if screening is going to be effective. And that's something I think is quite poorly appreciated. And those, even breast screening, the rate that they now do put in their information leaflets, that it's 2 overdiagnosed breast cancers for 1 where the screening made a difference to outcome. And the estimate for prostate, the equivalent estimate is 12 to 17. Thyroid is also very high as well. And just finally as well, the issue of all-cause mortality versus cancer-specific mortality. And this is a quite sobering meta-analysis of multiple screening studies across multiple cancers. And the only one that is sort of a sniff of statistical significance for all-cause mortality is sigmoidoscopy. This was published in JAMA a couple of years ago. And actually, just sort of slightly depressingly, some of these ones are absolutely on nullity. The main reason that you don't see an effect on all-cause mortality is going to be power, that your cancer-specific death reduction is so diluted in all the other deaths. It could be that they're dying at exactly the same time, particularly later onset cancers. You're just switching out your time of death. Or it could be that you have off-target harmful effects from over-treating cancers that are then sort of offsetting your cancer benefit. But that is a sort of quite often, they're beginning to give that information in the screening leaflets, that it may whatever the evidence suggests, it's around catching cancers earlier, but not necessarily living longer. So those are some issues with screening in general. And I'll just sort of talk a little bit about screening and interventions in that high risk context. So as I said, our screening studies that we have, our national screening studies, are based on the historic standards. You had to have 2 randomized studies showing benefit in cancer-specific mortality. That was what the National Screening Committee required to get over the line to start implementing the screening. So that was what the lung pilot required before they even moved forward. However, we have no randomized trials of any of the interventions we do in our high-risk people, because you could never do them. A, because it's a very small number of people, and B, you can't do genetic tests saying you're high risk and I'm now going to put you in the control arm. It just was never going to happen. So we have this range of interventions for screening in particular, and also surgery, where we don't have any randomized evidence. So all of those things that I have said to you about why we need randomized trials, we do not know if it's lead time. We do not know if it's selection bias of the people who tend to participate in screening, and we do not know the extent of overdiagnosis. So just a quick whiz through. So we'll go back to our genes, our HBOPP. So in terms of breast interventions, in terms of mammography, I won't kind of get, this is routine studies of mammography are old. So our sort of data on is from trials from the 1970s and 80s. And you can see actually even the older ones are where the benefit is. The newer ones, that I say newer, from the 1980s, this is your breast cancer specific mortality. The UK age trial, age 40 to 50, is not statistically significant. And this is all not taking account of the fact that our treatments for breast cancer have got so much better in the last 20 years that you've just lost a lot of that headroom for benefiting from screening. The more extensive follow-up of the UK age trial annual screening 40 to 50, published about 3 or 4 years ago. No, there's benefit when you measure it at 10 years, but by 20 years follow-up, there is no breast cancer specific mortality benefit, and quite a high rate of overdiagnosis and false positives. High risk screening, MRI. So this is a big trial. It's not randomized. So this is even with some selection bias in there. So overall, we get some benefit in breast cancer specific mortality. We get benefit in all cause mortality. But actually, interestingly, it has all been driven by BRCA1, which is a higher risk gene, more associated with triple negative breast cancer. So actually, that division gives credibility to the overall results, that it's sort of behaving as one might predict. So in terms of sort of thinking about this, breast screening at marginal benefit, but little evidence 40 to 50. MRI, you're only getting the benefit in BRCA1. In the States, they are offering extensive MRI annually to these women from a young age with these moderate penetrance genes only associated with ER positive disease. That is a lot of screening with zero evidence in terms of the mammography or really that the MRI will be having impact. Ovarian, as I said, big studies, no impact of screening. Prostate, bit topical. The population studies show benefit, but huge overdiagnosis. High risk people. Well, this is BRCA1. This is from the impact study. This is overall the division. Blue is low risk prostate cancers. Little evidence that they're different between the controls and the carriers for BRCA1. Some evidence that they're more aggressive for BRCA2 and they were younger, but no mortality data, non-randomized, non-blinded. So, you know, and this is with the screening committee at the moment. Pancreatic cancer, really problematic. There are no randomized studies. This is CAP3. If you do some pancreatic cancer screening, you do find them at earlier stage. If you compare people who trot along and have their pancreas manipulated to people who are in registration data, it looks like they're surviving better. But that's, you know, real selection bias. And that what's interesting actually is very, very small. There's 4,400 person years in their study, and they only found 9 pancreatic cancer. So it is a low frequency cancer, even in high risk groups. So really, in terms of screening, just very little data here, possibly high risk for BRCA1, but I mean, looking at the data, very little of it's very convincing. In terms of surgery, ovarian risk reducing salpingo-oophorectomy is pretty good. There is, these are nice data showing ovarian cancer specific mortality benefit, showing all cause mortality benefit, both BRCA1, BRCA2, where the risks are a bit lower in BRCA2. The question is, can you extrapolate from the high risk genes down to the more moderate risk genes? There's some modelling suggesting you can, but we're reliant on modelling. Breast risk reducing mastectomy is less convincing than one would like in terms of the data. There's lots of mixed data. Recent study from Manchester is null for either gene. This is a kind of large European study from 2019. And again, it's the same that you get all cause mortality and breast cancer specific mortality, but it's all coming from BRCA1, again, the higher risk gene with the more poor prognosis cancers, than actually in terms of looking at BRCA2, not statistically significant for either metric. So kind of consistent almost with the MRI data. So again, extrapolating this down to doing risk reducing mastectomy for these moderate penetrance genes seems sort of foolhardy, but common in America. And the tamoxifen trials reduces your likelihood of developing breast cancer, but no impact on mortality from the big analyses. And it is not trivial to take those drugs either. So again, good points, I think, for ovarian surgery, moderate for breast, but the chemoprophylaxis is kind of unconvincing in terms of outcomes. And those are the genes that we do a lot of. Those are our kind of rock solid genes. We're very confident we know what to do. In terms of all the interventions for these syndromic genes, we do all kinds of screening for all kinds of different cancers with zero randomized data. Imagine a whole body MRI. If I had a TP53 mutation, I think I'd want it. But, you know, the overdiagnosis and the likelihood of it, you actually impacting outcomes, zero evidence and probably unlikely. So I'll probably finish. This is a paper last year. There's lovely Mark we got together a bunch of people and tried for breast cancer to at least articulate clinical public health utility. And we sort of did that by, we did it by voting for genes, in terms of association, actionability, but clinical public health utility, and made recommendations of which genes you should test on a breast cancer panel, of which we recommended 6 in light of what is currently being tested across different panels being used in breast cancer. So I think just to sort of conclude, we are on a trajectory of more genes in more people, and that is going to be more pathogenic variant carriers. And I think we need this sort of system level joined up thinking, and to be really sort of mindful about our uncertainties about penetrance and risk, our uncertainties about the intervention, and this ipso facto around thinking about what metrics are important. So just to summarize, I've talked a bit about cancer susceptibility genes. I've talked about the SPED interventions. I've talked about the massive expansion of genetic testing of cancer susceptibility genes. I probably haven't really touched upon it. It's not my field. A genetic result is for life. You can't take these back. And I think the psychological implications and the opportunity cost of going to all these appointments and all these screening is not trivial. And also as an integrated healthcare in the States, it's kind of Wild West, you're on your own. Here, I think if we do the test, we as a healthcare service take on the onus of responsibility to manage the psychological and physical consequences of that. And that is not trivial, not least in terms of its cost. And I would say there's quite significant political and commercial impetus around doing more genomics, which isn't necessarily around public health utility. And that's both the testing and people who have suites of private MRI scanners. So I'll leave you with my 4 horsemen of genomic prediction: penetrance, pathogenicity, pleomorphy, and performance. I'd slightly get them all beginning with P. And thank my team and collaborators who I've chatted with about such issues. But thank you very much for listening.